Good afternoon, everyone, and thank you for joining today's webinar. I'm Dr. Sindhu Srinivas, Associate Professor at the University of Pennsylvania, Director of OB Services and Chair of the SMFM Health Policy and Advocacy Committee and member of the SMFM Board, and I'm your moderator for today's webinar. I would like to welcome everyone to the SMFM webinar on reactivation of clinical services presented by Drs. Chris Pettker, Alison Cahill, and Joey Biggio. Dr. Pettker is Associate Professor of OBGYN and Reproductive Services and Chief of OB at Yale New Haven Hospital. He also oversees Yale's Comprehensive Obstetric Patient Safety Program as Associate Chief Quality Officer. Dr. Pettker serves as a board member and Quality and Safety Committee member for SMFM. Dr. Alison Cahill is a maternal-fetal medicine specialist within UT Health Austin Women's Health Institute. Dr. Cahill is a prolific leader and researcher in the area of maternal-fetal medicine. She's a reviewer and/or editor for several specialty publications. She's a past SMFM board member and served as program committee chair for the SMFM 2020 annual meeting. Dr. Joey Biggio is the system co-chair of Women's Service Line and system chair for maternal-fetal medicine at Ochsner Health in New Orleans, Louisiana. He serves as SMFM board member and publications committee member. Before we begin, I would like to take a moment to share a few housekeeping notes about today's webinar. This webinar is being recorded and will be available to view on demand from the SMFM website. Following the lecture, there will be a 20 to 25-minute Q&A segment. You may enter your questions using the question and answer box at the bottom of your screen at any point during the broadcast. Please refrain from using the chat feature to ask the panelists questions. We promise to get to as many questions as possible during the time allotted. And with that, let's begin the webinar. Dr. Pettker.
Hi, everyone. Thanks for inviting me to give this talk. Opening and reactivating. Oh, somebody just put me on mute. Sindhu, can you just confirm you can hear me? Sindhu, can you confirm you can hear me?
I can hear you.
Oh, great. Okay, sorry.
We can hear you.
Thanks. I think somebody put me on mute as we were doing this. So thanks for inviting me to help with this talk. Obviously, the COVID pandemic has really affected operations. And the really interesting thing coming from MFM and obstetrics is that childbirth didn't really stop through this pandemic. So a lot of us and a lot of you out there have a lot of facility with working through the pandemic. But the reopening part of this is really scary. And I'm hoping I could just give a little perspective from a place that has been highly affected by the pandemic. So I did want to give a little bit of perspective on what we're going through in Southern Connecticut. And it's nothing like what people in New York have been going through. I want to make that clear, but we have been significantly affected. And these graphics just show where we are in per capita cases and per capita deaths. And this was a screenshot from the New York Times from April 28th. Throughout the month of April in Southern Connecticut, Fairfield County, and New Haven County and Hartford, Connecticut, were seriously impacted. These are the leading areas both for cumulative confirmed cases and cumulative confirmed deaths, as well as new cases and new deaths during April. And I think it's really important for me to give this kind of perspective so that you understand where we're coming from as a health system at Yale. And things really did shut down because of this. We really were forced to pivot into telemedicine, to shut down our operations as much as possible, both on the inpatient side of things and in the ambulatory side of things, and only do essential services, mainly related to COVID and continuing care that was essential in areas like oncology and obstetrics. To look at where we were last week as a Yale New Haven health system, and we're about 2,600 beds. We do about 10,000 deliveries a year as a health system. You could see we hit a big surge towards, when we hit our peak on April 21st, where we had about 750 admissions. So that's about a third of our volume was consumed with COVID patients. And you can see that the overall COVID inpatients, which is in blue on this slide, has steadily decreased over the last 2 weeks, and we're very thankful for that. But one of the really important things about our considerations as we reopen, particularly related to perioperative services, is that you can see that our ICU numbers have not budged, and our vent numbers have not really budged either. So this is our entire health system. So what's important to think about with this graphic is that as you're considering reopening, and as you're considering reopening critical services, you really do have to pay attention to all of the numbers, not just your admission numbers, but who's still in the ICU, who's still on vents, and how many of those patients, because we're going to have a lot of trouble at Yale New Haven Health System on reopening some of our really complicated perioperative cases with our ICUs being as full as they are with COVID patients. So I highlight this for perspective on where we are at the Yale New Haven Health System, but also when you're looking at your numbers in terms of how to reopen and reactivate your services, you have to look at all the numbers, not just the general numbers about cases and admissions and inpatients. I think everybody on this talk knows that there's a holy trinity of reopening safely and providing good services through the COVID pandemic. And the holy trinity really is about masks and PPE, testing, and screening. And if I didn't learn anything from this crisis, the best thing that I learned during this crisis was about how to manage a crisis and the anxiety around a crisis. And I would say the predominant theme for the past 8 to 10 weeks in our health system was the anxiety around personal protection, both of our patients and our visitors, but most of all our healthcare workers. And the first impulse when we're trying to manage that anxiety is to manage it by throwing PPE at people and saying we have the mask, by throwing testing and trying to say that testing is going to solve our problems, or to say that screening our entire population will be more effective at managing our anxiety. And I think the important message behind this is that you can't just throw these things at your healthcare workers and throw them at your patients and think that the anxiety is going to be solved with that. You have to have a clear and consistent message around these things to help alleviate the anxiety. You have to have a really systematic approach behind it with protocols and policies that talk about when do we wear the masks and the PPE, when is the right time to do testing, and how are we going to effectively use screening. So without a good message and without strong leadership with that message, you'll run into some problems. Two great successes, I would say, in trying to manage the message really carefully with our healthcare system has been with managing healthcare workers who are pregnant, in particular our residents who are pregnant, and what are the right places to be for them. And also with our medical students, trying to get our medical students re-engaged. Our sub-Is started this week, and trying to figure out how best to protect them. And the anxiety came from a lack of information with these people. And when we sat down with them and did our Zoom meetings with these individual groups, the directors for the medical student rotations and the residency directors, we sat down, we did the Zoom meetings, we showed them the information, we showed the policies. It was very helpful in alleviating their anxiety and going to their stakeholders and relieving their problems. So I'm going to go through in the next few slides on some policies and protocols that I think will really help us in our reopening. And I'm happy to share them with you if anybody wants to email, and these slides will be distributed. The first is related to the ambulatory situation and having a mask and PPE policy. And this page is just a snapshot from an 8-page document that talks about the categories of care, the types of patients or the population that are taken care of in those settings, some examples, and what type of PPE is supposed to be worn. What I think is very confusing is that people don't know when to wear a mask and when to wear an N95. And a lot of people think that they should be wearing N95s in all situations when that's not necessarily appropriate. So the relief of the anxiety and the protection of the healthcare workers comes from communicating policies like this and really spelling it out clearly for people. When is the right time to do this, and when is the right time to wear that? So I think it's imperative on our organizations to come up with these things, and Joey has examples in his slide deck too, but I'd be happy to share these with people. The most important thing is to communicate these things to people. And the struggle that we've had, and hopefully the speakers that follow me might be able to address this, is how do you get these out to the frontline workers to see these things to make them feel better? And we've done town hall after town hall to try to share these things. And some of our Zoom town halls across our organization have had thousands of our healthcare workers attending it. And that's been the best way to do that, the emails and the town halls. But if anybody else that follows me has any brilliant ideas on how to share these things, I'd love to hear that. We also have a very structured approach to patient screening and testing. And this is from another document, that's our patient screening and testing. So this is all patients who come to our ambulatory and inpatient sites. This spells out the rules for how they're going to be screened with temperature and symptoms, and how they're going to be tested, and what cases they'll be tested. I think it's a little bit easier for me to demonstrate on the next slide, which shows the algorithm, how things go. So it starts with an appointment getting scheduled, and then about 2 days before that appointment, if it's for a procedure or if it's for an ambulatory visit, like for an ultrasound or a prenatal care visit, 2 days before that, they will get a call from our scheduling center that will screen them for symptoms. If a patient has symptoms, then they will get triaged to follow the symptomatic patient guidelines. And I'll tell you where that goes on the next slide. If they don't have symptoms, then they continue with that scheduled visit. And if it's a regular outpatient visit, when they show up, as they walk in the building, there will be a screener that will confront them, get a temperature, ask them for symptoms, and if they don't have symptoms, then they'll proceed with their visit. If they do have symptoms, then they'll get shunted into a pathway very similar to how the pre-appointment visit got handled. That will go to a call center that handles these things. And so the screening has to happen at the door before the patient comes in. Actually, let me go back to that last slide. So the way that we handle those people who screen positive, you have to have a very good outlet for those people who screen positive, because you can't just send them away and say, good luck, we'll see you in 14 days. What you have to have is a system for how that patient will get assessed and how that patient will get tested. And we have a call center that we've been running for about 9 weeks now, that a patient can call this call center, get directed to a clinician for a telehealth visit, and these clinicians are trained in managing COVID patients, and that those clinicians will direct the person to get tested if testing is appropriate. And we have various different testing sites that do that. So the appointment will get postponed or canceled, but that patient will get taken care of for their COVID-related symptoms and condition, and will get cared for. And without that outlet for that telehealth visit and that call center visit, you're leaving people a little bit high and dry with what do they do next. So I encourage people to think about how they can take care of these people who screen positive, either at their, and when they're screened for their appointment 2 days prior to the appointment, or when they show up. We're also doing pretty rigorous healthcare worker screening and testing. We require our healthcare workers to do twice daily self-monitoring for symptoms and temperature. And we're also instituting asymptomatic screening. We started a pilot on that last week. So for patient-facing workers, these are physicians, APPs, midwives, nurses, our environmental services, the clerks, and our nutrition specialists. These people are screened daily, and we educate them with some strong recommendations that if they're feeling symptomatic, they need to self-isolate immediately. And where we've gotten into trouble when things started in March, and and where we had some trouble was people showing up to work and then noticing their symptoms and staying at work and trying to finish their shift because they didn't want to inconvenience everyone. And our message now has been that you need to leave work and call us, and we'll take care of managing your health from there. So we're really trying to encourage people to self-isolate before they come to work, or if they are at work and they do think they're having symptoms, to self-isolate immediately and to get out of their workplace. And this is another place where our COVID call center is taking care of people. We have an occupational health division of our call center where our employees and medical staff can call, see a clinician through a telehealth visit, and get tested as appropriate. And our healthcare workers get screening, expedited testing for COVID, where they can get results within 12 hours so that we can find out if they can go back to work immediately. The recommendations for continuation of self-isolation are another complicated thing, and this could probably be a whole talk in and of itself. But what we've learned at Yale New Haven Health is that using a 14-day self-isolation for people who are positive is probably the most wise way to go about it. And the CDC a couple of weeks ago changed from a testing-based strategy to a symptom and a time-based strategy. And the CDC recommends a 10-day self-isolation. And at Yale New Haven Health, we took a little bit more of a conservative self-isolation strategy, and we're using 14 days. And we're using the same thing for healthcare workers and for our patients. So if a patient is diagnosed with COVID through a COVID test, or if a healthcare worker is diagnosed as positive, we used a 14-day self-isolation protocol. And if they've improved their symptoms and they're afebrile for 3 days, they can come back to work. The most curious thing that we found out in looking at our occupational health data is that even with this 14-day self-isolation strategy, at days, our median return to work for our healthcare workers who test positive for COVID is actually 17 days. So a whole week longer than the CDC recommendation. This means that patients or our employees still have symptoms 50% of the time, up to 17 days after being diagnosed as positive with their symptoms. So that's kind of scary data to think that people are out that long, but that's why we favor this 14-day approach. And we are not retesting patients, and we are not retesting healthcare workers. And the problems with that, I think other people on this call might get to, but we have these enduring positive PCR results when people are not likely infectious. And it's not really a false positive because they're true positive tests, but these people are not infectious anymore. What the CDC suggests is that people are not infectious about 9 days after their symptoms, that there's been an inability to culture virus 9 days after the initial symptoms. And so that's where they get their 10-day data from. But we think conservatively 14 days is pretty reassuring. So what we're going to be going to with our ambulatory visits, and Joey's has slides that show a very similar approach, is to as contactless an ambulatory visit approach as possible. So we schedule the visit 24 to 48 hours before. We do a pre-appointment screening. And then the day of the visit, we have a huddle of our staff. We figure out who the known or suspected cases are. We plan the logistics around them. Then the patient shows up in the parking lot. We'll call a designated number to announce their arrival, and we'll wait in their car until they receive a callback to enter. The patient will enter when they're called. They'll be screened at the entrance with their symptoms and their temperature, and we'll take them directly to an exam room supported by a greeter or navigator if necessary, if they don't know how the office is arranged. The medical assistant or the nurse will greet the patient in the exam room, confirm the identification, and do an ID ban there. So people are not stopping at a front desk and they're not waiting in a waiting room. and that will complete the rooming procedure. The provider will then go and conduct the visit. We'll be wearing masks for all routine visits. And then the visit will conclude and they won't stop at the front desk to make their follow-up appointment. So we're trying to make this all as contactless as possible. And we're trying to use apps and we're an Epic house. We're trying to use MyChart for all of this. And then when that patient leaves the room, we call in the next patient to come after that room is cleaned. So these are just a few examples of what we're doing in our health system, and I hope that helps you. And I think Alison is taking over for me next.
Thanks, Chris. Yeah, so I just wanted to raise a few points. I think, you know, in looking at Chris and Joey's slides, I don't have slides for you today. I think many of the things that we'll see in terms of process will be familiar to many of you out there. Of course, you know, we just heard about things like waiting in cars, and people that are in the middle of big cities have to adapt different strategies for things like that. Here in Central Texas, our curve is quite a bit flatter, and you saw in those initial case density and death slides from Chris that there was nothing like that in our area. So the advantage for us has been, we've been kind of, if you will, a few weeks behind other similar flatter curves, and we've been able to learn from those things. I'll also say that I'm the chair for the Committee on OB Practice for ACOG, and a smaller set of that committee is the ACOG task force, and we're working with the CDC to put out the FAQs that hopefully have been useful to some of you. So I just wanted to make a few points, hopefully more for sort of for thought and for some backbone for some Q&A that other folks might be thinking about. So I think Chris's point about communication is really so critical. I think all of us felt that the stress of things when this just began, combined with the unknown, created so much fear and anxiety. So I think his points about having a plan, a very clear plan, having clear communication about what that plan is, and having clear communication and transparency about what sorts of things were suboptimal and being worked on and so forth. And I think, you know, the key pieces, I think for me, have been to really think about kind of healthcare workers, if you will, in the broader sense of what we all know, which is essentially thinking of the folks who are our essential in-person workforce. And we sort of walk by all these folks every day as we come into the hospital and so forth, who support really the entirety of the service line. So I think some ability to communicate well to everybody that's part of that workforce is really important. I think it's really also helpful to have both a regular cadence of communication as well as some clear communication, clear expectations around that communication. And so what I mean is, for example, our health system communicates 3 times a day electronically as one of the many ways they communicate. And so we know that that communication is going to come out from leadership. It clearly identifies new recommendations or new processes, but there are also clear expectations that everybody checks their email 3 times a day and looks for those and expects them. And then I think that the last piece around communication is to be sure that the folks that are on the front line have on-the-spot resources, is how I think of those. So as things arise, and questions on the front line, caring for a patient or a new potential scenario, to be sure that they have clear resources at their fingertips, or it's very clear to them who they're able to call. I think the next piece is about screening and how tests perform. And I think that this is really important when you think about integrating screening into your algorithm. So we all kind of know this, but knowing what the sensitivity and specificity of your tests are, as well as your prevalence in your area. Because if that prevalence is pretty low, then that obviously significantly impacts your positive and negative predictive value of your tests, and figuring out when you're going to employ screening, who you're going to screen, and how you're going to deal with those test results, I think is very important. Chris already touched on this, but I think everybody's grappling with return to work strategies. ACOG's publication on this came out on Monday night, I believe, and recommended kind of first symptom-based return for both patients and workers, but also if you do consider test-based strategies, to kind of know all of the unintended consequences, such like the cases that Chris was mentioning. The next point is, I think many of us are grappling with the use of telemedicine in our future state and our reopening state. I think one of the will be what S decides to do about its current very loose restrictions around telemedicine platforms, as long as you have patient consent. And I think forward going, many places would like to consider telemedicine in a more widely used way, particularly since reimbursement has become quickly much less of a struggle. But I think figuring out what patients and services are appropriate and still good care in that model, and also what sort of platforms we'll be able to use. And finally, I think for us, in the MFM space specifically, I think continuing to be thoughtful around how we handle parts of our service line that are particularly high volume and introduce close contact or closer contact than one might choose. So I think we've done a really excellent job at thinking about this with some data on labor and delivery services. I think we need to dedicate some thought as to how we handle this in other types of spaces, specifically to our practice, such as ultrasound, when sonographers spend extended periods of time in close contact with patients. So those are the few points that I wanted to raise with all of us trying to work through this and put our heads together to think about suggestions for best practices. I think Joey is up next with a few slides for you guys.
See if I can get this to share correctly. Okay, so what I want to go through is really some of the logistics of what's going on there. And, you know, as a health organization here in Louisiana that's really throughout the state started to look at what do we need to do to start to think about how do we get patients back. One of the things that I think that we have to all recognize is the fact that just like around the country, everybody was noticing that ED volumes were going down because people were not seeking care, and there was concern that patients with significant medical comorbidities and medical complications were not getting needed care. We felt like we needed to see what we needed to do to make patients start to feel comfortable in coming back to the doctor's office. And, you know, like Chris said, is that pregnancy never really doesn't stop. And so to some degree, some of the processes that some of the care processes that we provided never really ramped down that much, but there were certainly a number of things that did. And so, you know, as an organization, we engaged a number of focus groups to really address with patients what kind of things would they expect to see if they're coming back, and what's going to make them feel comfortable and that they're being kept safe. And so what this slide demonstrates is some of the results of the questions of those focus groups and surveys of what patients who would be coming back to the doctor's office would be expecting. And certainly one of the top things is that there's separation from patients who are positive, that patients want to see these sort of overt efforts in terms of hand sanitizer, that the space looks particularly clean and bright, that waiting rooms are actually practicing some degree of social distancing. They want to see people wearing masks. You know, we know there's a lot of the misinformation out there because they want to see medical staff wearing gloves all the time, the temperature checks, all the things that that people have routinely talked about. So when asked really about how comfortable and would they be in going to certain things, you know, for us as MFMs, because we're the doctor's appointment with the specialist, you know, they're going to be the most comfortable when they're coming there compared to all of these other things. And then again, you know, sort of their regular OBGYN, OB appointments, they're going to feel much more comfortable than with many of the other activities of living that they've not really done during the last 2 months of quarantine. So it sort of helps us start to move forward. So when we looked at how do we operationalize these things, we sort of took it from an approach of, first you have to set the stage. So that's where really this issue with regards to environments of care comes about, and that's where the focus groups really helped us. And so it involves, we set up screening stations for employees, for patients, for visitors on entry into all of the facilities with the temp checks, symptom checks. The waiting rooms were all redesigned with the goal of really not having patients in waiting rooms, but realizing that sometimes there may need to be some patients there. Setting up barriers for at registration desks, similar to what many grocery stores and other frontline facilities have done between the registration desk and the patient. And initiating processes that showed the patients we wanted testing, we wanted to know results by doing rapid testing for patients prior to procedures, prior to admission. And then just really emphasizing that the whole environmental cleaning and much more focused on maintaining a constant clean environment than ever before. With that in mind, then it really became the opportunity of how do we leverage some of the low contact or quote, contactless type stuff like Chris was talking about. And really, if we, obviously, we can't say that much to move forward from this whole pandemic positive has come, but the one thing that we can say is it really has, as healthcare professionals, pushed us to do things differently than the way we've ever done them before, and they really have been a launching pad for change and a driving point for innovation. And so we have really looked to leverage our digital connectivity to increase the safety and have really communicated that to our patients. And so we're on Epic and we have a pretty robust MyChart platform that we, in the course of all of this, have really pushed out to our patients to encourage that to be utilized as a platform for virtual visits. But now as we are reopening this, we are implementing mobile check-in and curbside arrival, and I'll talk a little bit more about that, but also really still continuing to offer and encourage other digital components. We have a program where we have connectivity with Wi-Fi devices that will allow patients to do some of their prenatal care at home, and so we have continued to push that out and have had tremendous uptake of that since the middle of March through the beginning of May. And then it's really a matter of making sure that that is communicated to patients and to the community so that people know that you're there, you're caring for them. So for us as MFMs, really thinking about how do we, when our offices are reopening, how do we let the practices that routinely refer know what's being done so that they can communicate to their patients what to expect, what kind of things will be done to keep them safe. And then beyond that, it's now the actual logistics. What are you doing? And it really relates to the fact of trying to make sure that those patients that we have put things off on because we felt like it wasn't an urgent case and something that could be delayed, that we're actually making efforts to get them in sooner and that, or as soon as possible, and that we're not just filling those gaps in the schedule with new patients that need to come in. We're going back and meeting the needs of those patients that we have deferred previously. And to do that, it may mean that we've got to extend some hours. We've got to really build the schedule up. So just as we look at, this is just some of the concrete examples of some of the things that we've done and set up at some of the facilities, but really increased the hand sanitizer stations that are there, set up these screening stations that really explain to patients upon entry into the facility, this is what's going to happen. We've gone through all of the waiting rooms in clinics, in hospitals, and removed chairs and put up barriers so that there isn't that temptation for people to sit anywhere within 6 feet of others. And then really emphasize the importance of social distancing with the footprints in terms of how to stand in line, how to stand in the elevators, and whatnot. So just a little bit more on the issues with making the patients feel safe. Like I mentioned, we're using Epic, and with my chart have really leveraged that with mobile check-in and curbside arrivals. And using that, we're able to send patients surveys to their MyChart account to complete, to assess their symptoms prior to arrival. It can be reviewed. If there's positive symptoms, we can provide direct feedback to that patient and direct them to the appropriate place so that they're not coming in and exposing people. If they are symptomatic, we can send them to a testing center. But it allows patients to, and it depends at each of our different sites, what works best, but it allows patients to check in from their vehicle and be notified by text when that provider is available. In sites where it's more of a one level type place, say one of our satellite sites, and a patient's in a ground parking lot, that's much easier than if it's at one of our more urban sites where a patient may be in a parking garage and quite a ways away. We still try to encourage them to wait in their car, but for some patients that may be a little bit more logistically challenging. And the one thing that we are able to do by leveraging this through the EHR is with some of the geofencing technology, we can also make sure that the patient's not checking in when she's still at her house for her appointment. So I've mentioned, I think, most of these other things, the screening stations, the sneeze guards, the changes in the waiting rooms, elevators, the sanitation standards, and really leveraging all of these other things. With regard to the personal protective equipment, Chris really talked a lot about this before, but the other aspect of this is that what I really, what we have had to do as an organization is really convey the message to our employees about the importance of the masks. Because I think if we all remember back to where things were when this all started in March, getting all the attention, people were saying, there's no reason to wear a mask. Why are you wearing a mask? And so so the message has had to be redeveloped and explained as to what the value of wearing the mask is, where you should wear the mask, and the importance of it for employees, as well as for visitors and patients. So in terms of ramp up of outpatient services, I think it really depends on the degree to which you were able to scale down your outpatient services. And I think you have to start to look at each of the different aspects of what we do as maternal-fetal medicine physicians. Some of it being, what's that timing that you really want to be doing your targeted ultrasounds, your otherwise routine ultrasounds. As we went into ways of trying to reduce contact, especially for our ultrasound technicians who can't be 6 feet away from the patient that they're caring for, we realized that if we were going to do anatomy scans on patients that were going to be challenging, we wanted to do them at the upper end of a window when we ought to have a better chance of being able to complete that scan than at the early end of that window. So we shifted from saying do an anatomy scan at 18 weeks more towards that 19 to 20 week window. And it was also based on risk factors and other things that might play a role in what may be found. Similarly, with regard to follow-up ultrasound intervals, we greatly spaced those out with the exception of all but the most high-risk patients. So you really have to start to think about what's the true need for scaling things back up and what's the appropriate time to do that. Similarly, it applies to sort of prenatal testing and antenatal surveillance of how do you, if you ramped things down, what is the most appropriate way to bring things back up, or do you stay where you are for right now? One of the issues that we dealt with early on as we decided how to do this was we knew that there would be patients who would be positive for COVID-19 who were in prenatal testing. And now that didn't take away their their increased risk for stillbirth associated with their underlying condition. And so we developed a plan and a facility in which to safely perform testing for those people who we felt truly needed it. And you have to think through all of this for each of your individual practices, facilities, and patient populations. Visitor policies is something that has been highly controversial and really highly passionate when you start to, for patients, when you start to look at what attention it's getting across the country. What really has to drive this is the fact that it really was all done to ensure the safety of patients and the staff to limit exposures. So through the pandemic, as an outpatient, we basically said that we have a no visitor policy. As we're entering phase 1, we still are sticking with a no visitor policy unless somebody truly needs assistance to get into the physical space where the clinic is. And at that point, they may be accompanied by one adult, no children. On the inpatient side, we continued throughout the pandemic to limit to one spouse, partner, or support person for women who were in labor, and that person would be allowed to stay with them through the hospitalization, but had to stay in the room. We now are, again, still limiting to one person, but that person would be allowed to leave and go home, but can't come back that same day. It's one person per day, and that's it. We had, because of concerns about the fact that doulas went between different hospitals, had restricted access with doulas during the initial process, but now with phase 1 are beginning to gradually allow the doulas to come back in. And all of these patients, all of these visitors, doulas, everybody has to go through the screening process for all visitors as they enter the hospital. The big part of all of it, like Chris alluded to, is really testing and making sure that there's a plan for how to do testing on patients to minimize exposures and minimize and to conserve PPE as much as possible. So we implemented a process in early to mid-April for testing of all patients on admission to the hospital with rapid testing at most of our facilities. Throughout the state, we are using the Abbott ID Now platform. There's one or two of our facilities that are using Cefiad. So a little bit slower turnaround time on that, but still generally within an hour. For scheduled procedures now, we are testing patients up to 48 hours before the procedure. And if they're positive, then it provides us with time, whether it's 48 hours before or if it's on the day of the procedure, if they haven't had the ability to get tested before. It allows us to make the assessment of the urgency of the procedure, the likelihood of being able to postpone it, and any risks of delay. We, for us as MFMs and in labor and delivery, it certainly plays a role with when are you going to do that scheduled cesarean delivery or that induction of labor on the patient with comorbid conditions or other circumstances. Because we've certainly had patients who have come in for routine scheduled cases, and lo and behold, they were asymptomatic positive. So this is probably, I don't know what version of this that this has been that we have gone through as a health system, but it reflects what we are trying to do in some scope with patients who are testing positive, in that if they're positive and it's emergent, you deal with it. You take precautions for COVID. Everybody uses PPE, and you do everything that needs to be done to keep the patient and the staff safe. If it's urgent, meaning, yeah, maybe you can delay it a little bit, but it's not going to be associated with immediate harm. We are trying to delay that for a few days. This says 72 hours because this is trying to address all surgical and procedural areas. But in labor and delivery, what we have been trying to do is delay for 5 to 7 days and retest at that point. If we retest at that point and they're negative, we'll retest them again within 24 to 48 hours. And if it is negative at that point, we proceed. If it's positive at that 5 to 7 day mark, then we just proceed and use precautions. I think when we look at all of this, the one thing that has become apparent is that there is no absolute right or wrong answer for any of these things. And it really is sort of a constant process of reassessing where things are, where they're going, and sort of in some sense, making your own rule book for your own situation here. So that's really all I had. I'm going to stop sharing my screen at this point, and then I think Sidhu can run through questions.
Thank you, Chris, Allison, and Joey for that great summary. So one question we have is, what are the policies that you all have regarding visitors for MFM ambulatory visits? And I think some of you touched upon this. And how are you kind of approaching the issue of whether if a patient declines to wear or keep a mask on during their MFM ambulatory visit, and this is a non-symptomatic patient?
Anybody want to go first? I'm happy to go first.
Go ahead, Chris.
So patients who are declining to wear masks and who are asymptomatic, we're trying to involve our patient relations people in handling those things first. I think a lot of people think you should call security on some of those people, but really we want to engage them in a positive way and try to teach them the appropriate behaviors. And we will postpone their visit, though, if we have to, for those sorts of things. For visitors, we still have limited our visitors to only if for ambulatory visits and basically MFM outpatient visits, only if somebody needs assistance in getting to that visit can they bring a visitor. We're trying to do as much of the FaceTime and incorporate as much of the new technologies to try to bring families to visits in those virtual ways. But we are really trying to limit our visitors right now because we do have a lot of community spread still in our neighborhoods.
Yeah, I mean, I think that what we're doing, I mean, I think I went over sort of what we're doing in visitor policies as the outpatient. We're not letting anybody in, and we are telling the patients that you have got to wear your mask while you are in the presence of the physicians, the ultrasound techs, and other staff. We've not really had, I mean, we've not had patients refuse, but what, at least here at our main facility, we have at some of the other sites. And basically, it's like Chris said, we've had the discussions with them to explain the rationale for it. And I think cordially what we would say is, it's your choice if you don't want to wear a mask, but it's our choice as to whether to provide the service or not. And we're not comfortable providing the service if you're not wearing a mask.
Yeah, I think that we have had a similar approach to what Joey is describing. And I agree with Chris that we want to sort of approach this gently. Again, we're in a little bit of a different spot because it's been several weeks now that the mayor of Austin has mandated mask wearing in facilities. So people are in masks everywhere in the grocery store and what have you. And so and our experience has been that most patients themselves actually feel safer when they're in a mask, and whoever's caring for them and staff and so forth are in a mask as well.
Great, thanks guys. Next question is, what are your current policies regarding patients who decline universal testing on labor and delivery?
So it's interesting, at our health system, we did about 800 patients in the month of April. And I think we had only one person decline testing. And that patient was asymptomatic and didn't have any high-risk exposures. And we just treated them with routine care and watched them carefully for symptoms. So we didn't have a high declining rate. It might be just due to the hysteria in our neighborhoods that everybody wanted testing, and so everybody wanted to participate in testing and thought that it was important for their care. And it could have been the way that we explained it to them as well. But I think some other people on the panel might have more experience than we did.
So we have not had a high decline rate, but we have had a few patients who have refused testing on admission. And initially the thought was sort of along what Chris was saying, is base it on symptoms and things like that. However, what we really found is that once we started seeing a number of asymptomatic patients come back positive, that the nurses became very concerned until they knew what a patient's status was, that they could potentially be exposing themselves. And so the stance we ultimately adopted for these patients was, and it's only been a handful of patients, and we've tested since we started, several hundred, probably close to 1,000 patients now across the system. What we have basically done is treated these patients like a PUI and encourage the staff to wear protective gear if needed, and have explained to them that because of the potential that they could be an asymptomatic positive, that the pediatricians will need to test their baby, and they'll need to be counseled on how they as a PUI will be managed and what the recommendations from pediatricians are with regard to how their baby will be evaluated and treated, because that baby will also be considered a PUI.
Yeah, I think that just more with my ACOG hat on, I've heard quite a few cases of folks declining, though that hasn't been part of our, kind of a major factor for us. But I would say that there are some unintended downstream consequences of someone getting tested who's asymptomatic and in fact remains asymptomatic or is mildly symptomatic for a day or two. And that's many of the things that people are struggling with regard to reentry. And so for pregnant patients around delivery, it could mean all of the things that Joey's talking about, but also sort of stories of brand new moms waiting in cars while other people take their brand new baby into their pediatrician visits and so forth. So I think that there's an article, I think on the front page or one of the close front pages of the New York Times today about sort of some of the stigma that folks are talking about. And I think that because of the downstream consequences, some patients might feel that testing or the inability to decline testing feels a bit coercive. So I think it's good to think about these things, even if they haven't occurred significantly in your space yet, depending on what your local practices or regional practices have been, because I think for everybody it will come up, and it's probably a challenge again around good patient communication and knowing that current status of how the pediatricians will manage that mom, maybe new mom, so that they're fully informed.
Great, thank you guys. Another question is, so for patients who tested positive for COVID but are asymptomatic, if they don't sort of have an urgent indication for an ultrasound, how are you approaching that? I think some of you talked about kind of the 14-day criteria versus or 7-day symptom-free, whichever is longer. We have one other question after that, but if you guys wanted to sort of briefly touch on how you're bringing people back for ultrasounds who are known positives.
Yeah, I think the 14-day from a positive test in an asymptomatic person is very conservative and is probably appropriate. The CDC recommends 10 days, and that's based on that 9-day of viral culture data that they have. But 14 days seems reasonable. 7 days could be potentially short. It's shorter than the CDC recommendation, which is 10 days. So using 10 or 14 days is probably appropriate for asymptomatic positives.
Chris, I think some of us are aware through kind of other channels of that viral data from the CDC, but do you have any idea when that could be available for more public or kind of research-based consumption?
I don't. I'm trying to bring it up with some people to try to figure out when that might come out. Right now, the only public data is something from Nature that was published last month, and then something in the New England Journal last month as well, but with very limited data about that 9 days. So it would be helpful if that came out from the CDC. And I think we just need to call our friends there to see.
Sounds good.
So one last question, I guess, and before the last question, I'll just say, Chris, some of your, or to many of your points earlier to all of the panelists in terms of disseminating changes, it does seem like one of the hallmarks of something that all of you all talked about was around very clear communication, both to patients and to staff about sort of processes, especially as things are changing, but also to try to kind of clearly reduce the stigma that some patients are feeling, and to also kind of make the staff feel like they're protected. And sort of some of the other strategies that we've used for that are sort of daily huddles, like in the clinic with the staff that's on for that day, because if you have somebody that hasn't been on for a little while, you know, lack of familiarity with things or lack of repetition makes people feel uncomfortable. And so that's been helpful. And then also sort of simming certain high kind of yield situations that are the most uncomfortable for people has also been helpful, as well as sort of sharing some of the data about staff exposures or staff infections or asymptomatic testing, and letting sort of all of your staff be aware of some of that data, and hopefully that will be helpful as well. The last question that we have before we end the webinars from a participant is that we've tested admitted observation patients with the Abbott ID now. Now that the negative predictive value is suspect and we are confirming negatives with the Department of Health test, which is a 24-hour test, concerns about even getting this rapid test until we have more dependable rapid tests. Anyone have comments on, I know, Joey, you mentioned a couple of different tests. Anyone have comments on sort of the different kinds of testing and some of the test characteristics?
So that was a big question that we had here when we first started using it, and because that's also the platform that our EDs used in terms of testing, and they had a lot of questions and concerns about the validity of those results. And so two things were done. So number one, we did sort of an in-house validation issue where patients got tested on 2 different platforms, and basically found that if you looked at the ID nows that were negative, and you then tested them on the 24-hour platform, the longer turnaround platform, which is again another Abbott assay that we use here. But if you did both, that there was fewer than 5% of the ID now negatives that came back positive. The difference, one of the key differences is in terms of sample collection between those 2 platforms. And that's ultimately where I think people felt like this was coming from, is that it had to do with the ID Now platform, it's a swab of the nares to the turbinates, whereas with the other testing platforms, including Cepheid, it is a nasopharyngeal or oropharyngeal swab. So it's going much further back, and it probably is a more thorough sampling procedure. The other thing is that with all of this, I know Abbott made some recommendations with regard to the type of swab that needs to be used with ID Now versus the other testing platforms, and that it's not using the same type of media or viral transport media as used with the other platforms. So I think it's sampling, and it's sample collection. And there probably is a small amount of inherent assay difference, but it's really more related to sample and sample collection.
I'll just add on to what Joey said. I think the person who submitted the question is actually referring to something that just came up from the FDA about the ID Now test, where negatives are being called, I think, presumed negative rather than negative. So they've really modified what those results mean. And I think that the FDA making them do that has to do with performance data that's out there. What I think what I've noticed a lot of is that we've forgotten a lot about the use of test performance characteristics and prevalence in a population. I think that some of the answer to this question is that it depends on the prevalence of the disease in the population. And general populations in some of our areas say that the tests becoming positive are somewhere between 25 and 30% in some areas. But on a lot of our OB units, the test positive rate is as low as 1% and maybe as high. Well, in New York, they had 13% at a period of time. And I think you have to really understand, if 95 to 99% of your tests are going to be negative, what's the utility of a test that you're not confident about it being negative, and where are you going to go from there? I think you have to think about those considerations, and the sensitivity and specificity of a test in a population where it might be 25% versus 1% is where you need to figure out where your next steps are when you're thinking about a test like the ID Now test.
Thank you to all of our panelists, and that was a really good point on sort of reminding us about the prevalence of sort of who we're testing in the population and how that impacts test characteristics. So I want to thank all three of you for your excellent remarks, and hopefully all of our listeners found it super helpful. Please feel free to email us if you have other questions, and everyone have a good afternoon. Thank you.
Thanks, Sindhu.
Thanks, Indu. Thanks, everyone. Stay well.
Thank you.